Welcome to a very special presentation. We are truly testing the Zoom abilities that we have so recently discovered as we're bringing Linda Robinson in from Malawi. A few housekeeping things first. I'm Linda Hayward, chairman of the board here at the Southwest Harbor Public Library. Kate will be handling things in the background, doing any of the technical stuff that needs doing. Kate will manage the questions as they come in and just handle everything. This is being recorded and it will be available to you in about a week. And if you are a registered person, you will get a notification that it's up on the library's YouTube. If by any chance the Linda in Malawi loses electricity, she will find a different way to connect with us and come back on. So hang in there. We'll take some conversation here or something. Make sure you stay muted so that you don't interrupt her during the presentation. I think that's everything I'm supposed to say. Put your questions in the chat and Kate will carry them on to us at the end. And now Linda Robinson. Many of you, I am sure, know Linda. She is a nurse, a midwife. She lives in Bar Harbor, but right now she's in Africa. And Linda, we are eager to hear about what you're up to now.
Thank you. All right, there's no way for me to gauge, but I'm hoping everybody can hear me. Otherwise, somebody will let me know, right? So thank you so much for this invitation. I am thrilled to be sharing what's going on here. So my plan for the presentation is to give you some background of how I got here and what my passion is for improving women's lives, focusing right now on reducing maternal mortality. And there are a lot of ways that this is relating to what's going on at home. So even though I'm in this tiny little country, deep in the heart of Africa, there are so many issues that are going on that relate to women all over the world. So just a little bit of background of how I got here. Years ago, I was a Peace Corps volunteer in this country. And when I came back to the United States, long life of raising family and developing my career. But in 2016, I had left clinical practice in Bar Harbor, and I really wanted to start looking at teaching and was looking to go overseas again. The organization that I applied to work with ended up sending me back to Malawi, where I had been as a Peace Corps volunteer, which is really cool. So from 2016 to 2019, I was working here and teaching at the university and had planned to come back sort of on this consultant basis to work on this project that I'm going to describe to you when the pandemic happened. So that kind of put an end to that plan. And when I was looking at kind of sunsetting my career, but looking at how could I get back and work for another year on this project that I care so much about. And that was when I applied for a Fulbright grant and I got it. So I'm here for this year working with Fulbright, which is through the State Department. And it's really exciting. So let's go on the next slide. Okay. So I want in my focus on reducing maternal mortality, I want to just start with a global look at universal rights of childbearing women that were developed by United Nations and World Health Organization, because I feel it's important when we're looking at women's health and women's issues to frame it in this global narrative that it's a human right. It is a basic human right for women to have the healthcare that they need and deserve. So these are actually like written and have been developed, and they're out there. It's just that I think we're socialized to, in many instances, to just accept, whatever we can get without without the mindset that we have a right to be treated well. We have a right to information and to informed consent, and we have the right to refuse care that we do not choose for ourselves. We have a right to confidentiality. We have a right to our privacy. We have a right to be treated with dignity and with respect. We have a right to equal treatment, no matter who we are or what our social circumstances are. We have a right to timely health care, which is a big issue in our US healthcare system now, and the highest attainable level of healthcare. And then liberty, self-determination, and freedom from coercion. And freedom from coercion, I talk about a lot when I'm talking about respectful childbirth, because there are many women who are coerced into procedures and invasive care that they actually don't need. Okay, next. Next slide. So we're focusing when I'm teaching at the university in the midwifery program here, and we are in the classroom focusing on respectful care of women, which should be a given everywhere in the world. But there are many aspects of care that women experience here and around the world. And this is just a list of some of the conditions that women face. That picture there is an example of what I consider horrific care. So this is in the teaching hospital here, and twice a day rounds are conducted with in the medical school. So these are residents, and there's just hordes, like a huge group of people go from bed to bed. And in the spirit of, or with the intent of clinical learning, without really the recognition that it is a human being that is being treated as a mannequin. So this, I just kind of wanted to set the stage, because when our students go into their clinical experience, this is a lot of what they're witnessing. That's the students. This just gives you an idea of what the women are experiencing. So it's a lot of like 1950s and 60s in the United States. Okay, next. So I just wanted to put these statistics out there because this is really what I'm going to be focusing on. So when we talk about maternal mortality rate, it is the number of deaths per 100,000 births. And these are broad categories, but I wanted just to give you a comparison. These are WHO numbers, and between 2017 and 2020, 2020 was the last set of statistics I could find. So you can see in Europe and the United States, maternal mortality rates are going up. Shocking. I rail about this all the time. And I'll get into some of the reasons why. But in Malawi, interestingly, they are going down. And the thought is has been a much higher focus on contraception in Malawi in the last 10 years, really. And that since there are fewer women having many, many pregnancies, there are fewer maternal deaths. I put in South Sudan because it is the highest maternal mortality rate in the world, because it is a country that has been at almost constant conflict for about the past 20 years. And war and conflict is a huge factor when we're talking about maternal mortality. Okay, next. So I just put this map up because a lot of people don't know where Malawi is. So just to give you a visual, and I realize I don't have a pointer here, but if you look at the bottom right of the continent of Africa, oh, great. There you go. So Malawi, if you can see Mozambique, Malawi is just to the right there. So just to the west of Mozambique, east of Zambia. It's the tan country. It's a long, narrow country sandwiched in. There is no, it's landlocked, but there's a huge lake that's almost the size of the country. It's area-wise, it's about the size of Pennsylvania. It was a British colony, and because it has no port, and has very few resources, has almost no resources to export, it hasn't been exploited as much as some of the other colonies. So it's been a relatively peaceful country. It's been a very peaceful country. Got their independence in 1964. But most 84% of the population are subsistence farmers. So they are one of they are the second, I think, poorest per capita country in the world. Okay, next. So just to show you where I am. Next slide. All right. So when we look at like why do women die in childbirth? And I just listed the most common reasons. So most of the maternal deaths are from hemorrhage. Next is from obstructed labor. So these obstructed labor, women die from that in areas where they don't have access to safe surgery. Eclampsia is a common complication of pregnancy where women have high blood pressure and can seize and die from that. It is treatable and controllable as long as women have access to healthcare. Sepsis is infection, and the increase, this is one of the reasons that the maternal mortality rate in the United States is going up. It's because the more invasive procedures you have, the more risk there is of infection, and you can die from that. So unsafe abortion, very much highlighted in our country now. In countries where there is not access to safe abortion, it is one of the highest causes of maternal mortality. And embolism. Embolism is a blood clot. That is one of the very rare conditions that can cause a maternal death that we can't predict or prevent, really. However, surgery does increase your risk of that. So almost, except for embolism, almost all maternal deaths are preventable. I want to highlight that. Almost all are preventable if women have access to safe and competent care. Okay, next. So I was looking up, like, what are the WHO guidelines for reducing maternal mortality? And this is their 2024 statement, so the most recent. And they're all incredibly broad and kind of, you know, general. First is increase access to maternity services. So this is what I work on and am going to work on at home, because in the United States, the maternity services in rural areas are disappearing, and women are having to travel further and further to get maternity care. Universal health coverage. So if women can't afford health care, they have a lower quality of health care. So and one of their guidelines is collecting accurate data. So we need to know really what it is that women are dying from, the actual cause. If women die from a postpartum hemorrhage right in front of you, I mean, you've got that good, accurate information of what the cause of death was. But most maternal deaths in developing countries happen after the woman's gone home. And we don't really know, we don't have accurate data of what caused those deaths. and then to actually address the specific causes. Okay, so next. So this is the recommendation from the United Nations Population Fund, that we could reduce maternal mortality with quality midwifery education. Okay, and so this is what I'm all over this. I completely believe in this all over the world. So it's cost-effective and acceptable pathway to reduce maternal and newborn morbidity and mortality. So that is the most recent statement from the United Nations Population Fund. Okay, next. And then how do we provide that? Okay, so it's more likely to be achieved when programs provide quality clinical skills, education, and clinical experiences. So next, I'm going to give you a little context of what's gone on in Malawi with midwifery practice and education. So when I was here as a Peace Corps volunteer, that was I arrived here in 1979, and I was a public health nurse. And I had never intended to practice obstetrics. I mean, it was in like my obstetric education in nursing school in the 70s in the States. It was super invasive. Women all had spinals. Babies were all born with forceps. And I was like, I never wanted to do that. I never wanted to be part of that system. And there were hardly any midwives. Like, it was like childbirth was incredibly medicalized. So I came here as a Peace Corps volunteer and a public health nurse, was in a very rural part of the country in the very far north. And I was working with the midwives. So in most of the world, public health really is maternal child health. So that's mostly what I was doing. I was working in under 5 clinics and prenatal clinics, and I was watching how these midwives practiced, and I wanted to be just like them. They ran the hospitals. They could handle any emergency. They were incredible role models. And I had just decided, like, this is who I want to be. This is who I want to be. I came back from that experience and felt like I'm going back to school. I'm going to be a midwife. It's the only way that we're going to make the whole pregnancy, childbirth experience better for women in the United States, is through midwifery. So I, fast forward, I come back here in 2016, where they had 25 years previously started a medical school. And I saw a huge shift in how the midwives were practicing. So it was more and more like the Western model of care, where midwives were their independence. Even though they're licensed to practice independently, they were more and more standing back and letting the medical model roll over. So when I started teaching in the program, then I was talking about this to some of the older midwives who actually remembered what it was like to have complete independence. And just sort of like, I was shocked at the difference, and felt like we sort of imported the worst of our medical care. And so students were not seeing the model of care that I had witnessed when I was here, back in the 70s and early 80s. Okay, so next slide. So at the teaching hospital here, I'm, the university is associated with the big teaching hospital here in one of the second biggest city in Blantyre. And the referral hospital is called Queen Elizabeth Central Hospital, and it's the teaching hospital and the referral center for complicated cases. So it would be the equivalent of, like, Eastern Maine Medical Center or Maine Medical Center in Portland, Maine, that you've got smaller rural hospitals and health centers, but then if there are complicated cases, they get referred to the teaching hospital, which is the tertiary care center. So what happens, though, are women who are not high risk often get referred to the high risk hospital for reasons other than a complication. So if there's no staff at the health center, or if they don't have, they don't have any suture, or they don't have any Pitocin, or they will just get sent to the referral hospital. And I would like to point out, this happens in the United States too. It happens in Maine all the time. When you close a rural maternity ward, all those women get funneled into the tertiary care center, which was never designed to take care of that size population. It was designed to take care of the complicated cases. So what happens when the uncomplicated cases come into that system, it becomes incredibly overcrowded, and then their care becomes medicalized, often because they need the space. So women are not allowed, they're not given the time to have a natural, normal birth because it's too crowded, and the C-section rate skyrockets. It's exactly what's happening at home. Okay, next slide. And what's happening with the students, because there's a very high birth rate here, what the government system way of addressing that was to educate more midwives. So they admitted more midwifery students to the university, without really working through what that kind of education was going to be. So the classrooms are incredibly crowded now. I mean, I'm happy with the thought that they need midwives. I wish this was happening at home. But the education system hasn't caught up to that, to actually providing a quality experience as a student. And because we have so many students, when they go out to their clinical sites, they're unsupervised. So students with no experience are getting sent out to clinical sites and actually practicing without supervision. Not a good situation. So when they get out there, they're seeing unsafe practices, they're seeing disrespectful care, they're seeing invasive procedures that don't need to be done. So big problem. Okay, next. All right, I'm going to leave this up for a minute and tell the story of what happened here. So this actually happened in 2016 when I was on my way out to one of the district hospitals. So it was like an hour and a half away. I arrived to supervise these students and to do some clinical teaching, which they should have a preceptor with them all the time. But because we have so many students and we're going to so many different places, our supervision and our teaching is very sporadic. So I arrived at this teaching hospital, at this district hospital, sorry, to see these 3 students. They were 4th-year students, so they were graduating soon. They were standing at the end of this woman's bed, and this woman was writhing in pain. So I said, what's going on? And they said, she's going to the theater for a cesarean section. I said, why? They said, because she's been here since last night. Okay. I went, that's not a reason to do surgery. So I could tell by the way the woman was acting, that it was pretty possible this delivery could happen soon. So this is an example of, she's been here too long. We need this bed. We're going to take her to the operating room. Now, I do want to make sure everyone understands that cesarean sections do save women's lives if labor is obstructed. If it's not needed, the woman has a 3 times greater risk of dying from childbirth than if she had a vaginal birth. C-sections, when they are needed, save lives. When they are not needed and they're done for convenience or because for a non-medical reason, they can be lethal. So while I was talking to these students, they came from the operating room with the gurney to take her away to the operating room. And I turned to the clinical officer and the people I said, can you just give us a half an hour? Can you come back in a half an hour? because I really think we can get this woman delivered. So they said, okay, and they left. So I looked at the students and I went, all right, you're going to listen to me. You are going to support her. You're going to hold her legs. You're going to encourage her to push, because I examined her and I could see the baby was right there. So they, they responded beautifully. Okay, so we encouraged her. We did the delivery. 1.5 hours later, they came back to take her to the operating room. And this picture right here is what they found. She was breastfeeding. The delivery was done. She had an intact perineum, hardly lost any blood. And the students all looked at me and said, Madam, we have never seen this. We've never seen anyone question the doctors before. And it wasn't like I was obnoxious or, disrespectful. It was, I just explained that I really felt like we could manage this, and they responded. And so this situation is what made me go, what are we doing? These students are not they're not witnessing, or they're not seeing midwifery care modeled. It was just luck that I happened to walk in at that time, that we could have this experience. So I had been thinking about this and thinking about this. I was so distraught when I left there. I was happy about this. I was happy about the outcome, but I was talking to the dean of the program, and I was telling this story, and she said, I know. We all know that this is a problem. And she said, and I've had this vision that we should start a midwifery ward at the teaching hospital so that we can actually model midwifery care, and these students can see, how they should be practicing. Okay, next slide. So let me just, run down what the midwifery model of care is. So it's rights-based, human rights-based, childbearing women's rights-based. It's respectful. It supports physiological birth, so natural childbirth where it is the safest option. Working in partnership with women, talking about what experience is important to them. And since we're not surgeons, we have to collaborate with other health professionals if we identify a complication that is outside of our scope of practice. Okay, next slide. So when we talk about a midwifery-led ward at the teaching hospital, this is what we're talking about, where the midwife is the lead healthcare professional. Midwife is responsible and accountable for planning, organizing, and providing the care. And it is not under the direction of a physician. Okay, next slide. So this was the vision that came out of the discussion I had about that one, experience, was that we could develop a self-sustaining midwifery practice within the tertiary care hospital. So instead of our students going over to the high-risk ward, if we had a ward where all the normal, the patients who were referred for reasons other than a pregnancy complication, if they all went to the midwifery ward, we could care for them there. We could be modeling right there at the university the care that women should be getting with the midwifery model. And so we were proposing a 6-bed labor and delivery unit and an antenatal and postnatal ward that we would collaboratively manage with the university midwives and the Ministry of Health midwives. So all the government hospitals, all the staff is all government employees. So they're all under the Ministry of Health, and would follow the International Confederation of Midwives protocols and standards of care. So it just was like, we're so excited about this model. Okay, next. So these were our goals, to model the appropriate midwifery care to the students, to empower midwives to function as independent providers as they always traditionally had practiced here, to promote respectful care of women, and to reduce maternal and neonatal mortality. So it's, very clear. Data shows all over the world, if women are cared for by a skilled provider, their risk of dying goes way down. Okay, but we are either making it too difficult for them to access that care, or too difficult to provide the education for midwives to function as a skilled provider, providing respectful care, because they're not witnessing it in their education. Okay, next. So this was our initiative, obviously. I mean, it's just pretty much reiterating what I just said. It's respectful care of women, to have safe clinical judgment, and with that, gain skills in dealing with situations that now, like, for instance, okay, so retained placenta or breech birth, those situations now, the medical students and the residents just like swoop in and take over. So the midwifery students are not getting hands-on experience managing those. And therefore they have less and less confidence if they do come upon that situation when they're working. And really to have a professional identity as independent practitioners and not support staff for the medical field. And then promoting childbirth as the normal physiological process, which is time consuming. Let's face it. I mean, nobody goes into obstetrics because it's a convenient specialty. And if we rush it, we are causing way, way, way more problems. All right, next slide. So this is how, and again, this is 2017 when the idea was blossoming. So we got a small grant for seed money to begin this project. So when we started talking about it, like, everybody was like, this is exactly what we need. Everybody supported it. There was always recognition that this was a problem, that midwifery education was the problem, that the maternal mortality was too high. We didn't have to convince anybody of that. So we got a seed grant to start the project. Okay, next. And then we wrote up a formal proposal, and we met with key stakeholders to just sort of to put forth the idea. We wrote up an executive summary, and I mean, we met zero opposition. I was stunned. I mean, even the medical school, the head of obstetrics and gynecology at the hospital thought it was a great idea. Like, everyone recognized that it was a problem. So that was awesome. I was used to a lot of territory conflict at home. There's a lot of physicians don't want to give up their control and territory, but that was not the case here at all. Okay, next slide. So then we had to say, okay, all right, we got permission. Everybody thought it was a great idea. Where are we going to do this? And so we found there were some sites at the hospital that weren't being used. And we were looking at, kind of talking about what might work. And the head of the head of obstetrics just gave us he said, just take Ward 1A. It's like hardly anyone uses it. And we just couldn't believe it was that easy. So we were given the space, and we had, the will and the enthusiasm. Okay, next. And we were talking about it throughout all the midwifery groups in the country then. So this picture here is the parade that we have on the International Day of the Midwife, which is a big deal here. And we had a forum to present this idea. Like, we in Blantyre, we are developing it here at the teaching hospital, but really want it to spread everywhere in all the teaching hospitals. There are 3 teaching hospitals across the country and at home. I mean, in the United States, this is a model that could be used everywhere. I'll talk about that in a second. So we took advantage of the public events to introduce the idea and gather support. Okay, next. Then we were presenting it to, this is the Minister of Health, who was present at the International Day of the Midwife. So there was support all the way up the food chain. It was great. Next. And then we found there was a hospital in South Africa who had done the exact same thing. And so we took a trip there to see how they set it up and presented our ideas and got ideas from them on how to proceed. Okay, next. And then we formed committees, and the more we did this, the more buy-in there was from everybody working in maternal health. Next. And then we got input from the stakeholders regarding staffing and logistics, because we were never going to have enough grant money to like hire all new staff. So we had to figure out a way that the faculty would be working there, but also Ministry of Health would be staffing it. Okay, next. And then formalized standards of care. So these were all this was just like cookbook, how the step-by-step, what we were doing. Next. And then we had architecture students who were interested in global health and were focusing on maternity centers. So they wanted to submit some plans for renovating the ward we'd been given. Next. And this was one of the plans that was submitted. Next. Okay, and so then what happened, like one of the things that we were like, well aware of is that people only have so much time and energy, and everybody has full-time jobs. So, this was an extra project. So we were taking that into account and how we were going to allocate resources. And then we had the pandemic. So what ended up happening was the ward that we had been, it was about to happen. And the ward that we had been given at the hospital got taken for a COVID ward. It was the only place that they had oxygen. So it just disappeared. Well, that seed money that had been allocated, they didn't want to lose it. So, because there was a 5-year window to be used. So that money went to one of the health centers nearby to improve their maternity services, which it did. It has definitely, like, they have curtains now. They have a place for the midwives to sit and do their charts. I mean, they definitely made improvements, and that's all great. But now that 5 years is ending, and the original goal, the original vision of this project was just kind of hanging there. So when I was writing up my application for the Fulbright, it was in collaboration with the faculty here. It was like, I am willing to work on that this year. If we still want to go back, even though there was a major setback, do we want to go back and try to re-energize that? So next. Yeah, so here's where we stand now. I want to just explain that everyone is overwhelmed with how much there is to do. I mean, that's not unique to here, but it's just a fact. And so when I got back here and was, sitting down talking with a few of the original visionaries here, it was, do you want to try and get this going again? And they really felt like, well, that the seed money went into this other clinic and kind of there was kind of this deflated feeling of like, it's never going to happen. And I went, look, I have a year, I'm here, and I'm willing to see if we can re-energize this project. And in talking, I talked to a few of the original people individually, and yes, they do. They were like, yeah, we would love it, but not quite sure where to start again. So I was like, okay, well, we planned this meeting, and some of the they call them matrons, they would be our equivalent of our nursing supervisors, have actually gotten promoted to a level where they're at the same level of the head of the OBGYN department. So they have a lot more decision-making power. And felt like, yeah, this is a legacy that we want to leave. So we met again. It's a new head of OBGYN this time, but went through all the same problems still exist. And, but the money, that seed money, isn't available anymore. So we just started talking about, and the ward is gone, like the space is gone. So I had been talking to some other people who had been doing projects here and writing grants for much bigger projects than what we were looking for to renovate that place. And I just said, what about, I mean, if it were possible, if I could write a grant to, for something bigger, is there space here on this campus that we could actually build something that we really, that's our dream, that would work, instead of trying to renovate something that we're making do with? And like I said, some things are really hard to accomplish here, and some things are super easy, like getting permission. It was like, sure, yeah, I'm like that's it. Yes, like we can do this. And we walked around, the campus to see where it would be feasible. And it's just like simple. Like, we have permission for a building. The whole philosophy and vision and goals of the original project are still there. It's just now we're kind of at the point where, like, let's just go big. And so that's where we are now. We've got permission, we've got the hospitals bought into it. And so I'm in the process now of writing a much bigger grant than we had before for actually building what we need. So there is an architect in Botswana also who just got a Fulbright, who specializes in birthing units. So she's coming to Malawi end of this month, end of May. And we're going to get a plan drawn up. And I've got a couple of organizations in Switzerland and Netherlands that fund these kinds of projects. So kind of exciting. I think there's just one last slide that I have that I found inspiring, because there was so much feeling of like, yeah, that would be great, but it'll never happen. So what I'm going to I'll open it up to questions now, but what I am most excited about with this is how universal this should be. Like, we should have this at home. And I will go off on that tangent if there aren't questions. First, I'm going to just check and see if anybody has like questions about what I've already covered before I relate it to what we're doing at home. Or back in the States.
Right now, this is Kate. And
okay.
Right now, we don't have any questions right yet.
Okay. All right. So let me just relate this to what's happening in the States. Midwifery education is, how to say that? When I was going to midwifery school, there was this feeling, because of the way hospitals got reimbursed and maternity care got reimbursed, that the midwifery education system would grow and grow and grow. Schools were opening up across the country. But then when reimbursement changes, standards of care for maternity services change. And what's happening now, I mean, in addition to all the small rural hospitals closing their maternity wards because, quote, it's too expensive, which I maintain is gender discrimination. It shouldn't matter what it costs when there is a need for a service that is perennial. It is the one thing in medicine that is never going to change. Women are going to reproduce. And the fact that we are saying as a country that it's too expensive to provide that service to rural women is unacceptable. it's discrimination, and it's an abuse of a human right to not provide that care. So those, as I alluded to before, all those women are being forced to travel hours to the tertiary care centers. Those women are having increased numbers of cesarean sections because they're being induced, because they're afraid they're not going to make it to the hospital in time, because they have to drive 3 hours. They're women that are poor and can't afford to be away from their families like they're forced to be now, and that they have to travel outside their communities. And what's happening in midwifery education is the students have to find their own clinical sites. So midwifery students have to, lobby practicing midwives to take them on as a preceptor. And it's getting harder and harder and harder for students to find people that will take them. And so there are students that are dropping out of school because they can't get their clinical experience. It's outrageous. So this model that we're proposing here, it would be a perfect model for our tertiary care centers at home. I mean, why aren't there midwifery wards in the teaching hospitals for these women who are being referred to that center, not for a problem, but because their maternity ward in their hometown closed? They're not high risk. They should have access to care that allows them to labor in their own time with a safe and competent practitioner. So if we had all the teaching hospitals had a midwifery ward where all the normal, uncomplicated women like went to that ward, and we had teams of midwives to care for them with the midwifery model of care, it would be a better experience for everybody. They wouldn't be overcrowding in the high risk wards. The high risk patients would be getting more attentive care because it wouldn't be overcrowded, and there would be a clinical site for midwifery students. Like, there are no medical students that have to go begging for a site to do their clinical rotations. So why should midwives have to do that? Why should that be part of their their chore as a student? So, when I got back here to Malawi and was, presenting this again, I went, this is your life and your ward and your jobs. And, I don't want to be pushing it. I will work toward it. I completely believe in this model, and I am a great cheerleader, and I'll do whatever I can to promote it, because it is a model that we could be using all over the world. And why? And I said to the dean here, I said, why shouldn't you get credit for it? It was your original idea. Why, if we can implement this here and write it up, just cookbook style, because when I go around talking about it, everybody thinks it's a great idea, but it's just like, but we could never do that. Well, we can do it. We just have to step by step figure out how. So that's where I am, and I'm excited about it. I really am. I really, really believe in it. And I went to the International Confederation of Midwives. They have a huge meeting every 3 years in a different part of the world. And I went it was in Bali in June, and I went, and I'm telling you, these problems are all over the world. It's not just in the United States. It's not just in Malawi. There were, like, I talked to midwives from Denmark who are complaining about the same thing. I'm like, I thought everything was great in Scandinavia. I can't believe this. And so that's another reason why I feel so strongly that if we could get this off the ground in a place here where everyone already agrees that it's needed, we would face many different obstacles at home in our medical system back in the States. But just if we can get it going, collect data, show that this model of care can reduce maternal mortality, then, you know, we'll have done our part. So is there another?
Linda, that was, yeah, I've got a question from Deneen. If you're able to bring this model back to the US, where do you start to get up and running? Local hospitals, government?
Haha. Yeah, okay. This is, yeah, where would I start? At home? Well, we have a national organization, but I think and I've talked about it there and presented this whole model there again, it's not hard to get people enthusiastic about it. You know, everybody thinks it's a great idea, but it would mean working toward getting it established. And I would, oops. Oh, am I still on?
Yes, you are.
Okay. I would think getting it established in one hospital, if I'm going to be working on it, it would probably be, you know, up at Northern Light in Bangor. I mean, it's a perfect place for it. The whole 2/3 of the state of Maine have no maternity services. So, it would be, you know, it would be a vision that I would have, that if we could get it going there, the problems of getting buy-in from the hospital and blah, blah, blah at home would be much different. But I can dream. I mean, that's where it's needed. I mean, and you look at the original statistics. I mean, the fact that the United States has an increasing maternal mortality rate should have everyone wanting to do something about this. So, you know, once we can feel secure that our democracy is safe, you know, maybe we will have energy to then start protecting women. I mean, I'm hopeful. I think there's a lot more public awareness of this now because of what's going on politically. So, I mean, but it would be at a teaching hospital in an area where where what we call maternity service deserts, which in northern Maine is a huge desert, mostly in rural areas, but that's happening all over the country.
Wow.
Ooh.
Wow. Linda, this is just amazing. Good luck. I hope this can happen. When is International Midwifery Day?
Oh, it's tomorrow.
Whoa, wonderful. Well, this, I didn't realize myself how timely this was. Oh, thank you so much. I didn't even know there was such a thing. I
know, well, it's not a big deal in the States, but in countries that their, you know, healthcare for women absolutely depends on midwives, they're much more highly recognized. They're actually, so I was talking to Kate about, like, I'm not sure where I'm going to be because usually there's a big celebration. So I wasn't sure if I would be up in the capital city. But a notice went out yesterday, actually, that they're postponing the celebrations until the beginning of June. So they literally have bands and a parade. It's awesome. I love it. I'll take videos and I'll send them. Yep.
Oh, that's just incredible. And as it should be. I find you very inspiring, and I certainly hope you can bring it back here and maybe get Northern Light to do something. Just a little side note, Northern Light is closing their clinic here on Mount Desert Island, so that people will now have to go to Ellsworth to see a doctor associated with Northern Light. So, I mean, that's not just women, that's everybody, but just think of that pregnant woman who used to be able to just go to Herrick Road in Southwest Harbor, and now she's going to have to go up to Ellsworth to see a doctor.
I know, and I get crazy about this when when, they'll close, they close the maternity ward in Lincoln or, York, all these health centers, and they go, well, it's just, it's only an hour to Bangor. I'm like, yeah. And like, if you've got a car, if you have gas for the car, if it's not snowing, if you don't have 3 little kids at home, I mean, that is just so callous. It is unacceptable. But the women who are most impacted by that are poor, rural women who feel that they don't have a say.
Yeah.
And feel powerless. And so if we can help to educate them and help them understand that they deserve this, they deserve better care, they deserve services in their community. I mean, baby steps, but yeah, it's the overall bit.
Well, you are certainly inspiring, and I wish you the best of luck in getting it done in Malawi, and then bring it home, and let's hope you can you can't do it alone. So I hope that midwifery schools across our nation band together to help you do this and are inspired by what you're doing. And you've done this presentation for us. I think that's incredible, but we're probably not totally the right audience. You need to be talking to these doctors. And
yeah, no, I believe me, I do. I any chance I have. I've talked to, I know we're almost out of time, but again, right before the pandemic, I'm looking at all different ways to raise awareness of it. And I mean, it was like beginning of March 2020, I was talking to 2 Bangor reporters about, could we just do interviews with women in these rural, communities who've lost their providers and lost their maternity care, and see how it's impacting their community. And because people respond to individual stories.
yes.
So that's another thing that I want to do when I get home. I mean, I want to go around and just sort of interview women in the communities and see how it's impacted them, and see, we have to go at it from all different angles. It's exhausting, something that should be just a right, that, little by little, these things get taken away, and, and we're just accepting it, and we shouldn't.
No.
So,
and as you say, we have many battles to fight here at home so that we're ready to fight this one.
Okay.
Yeah. Well, I see Kate is here. Kate, is our time just about up?
Yes, it is. But I wanted to let's see here, spotlight, to mention that thank you all for coming, but we will be putting this recording up in the next week on our YouTube channel, and I put that in the chat as well as the blog to follow Linda's adventures. And there's one, the exciting one about you trying to get on a ferry. I guess it was back in March when we were trying to do, or getting from one place to the next. So it's quite a lot. So wonderful. And you know what? Spread the word. We'll be putting this on our YouTube channel, and people can watch this. This is so important. Thank you so much, Linda.
Yes,
Thank you,
Linda. And thank you everyone for coming. Those of you who are here on this beautiful Saturday morning, thank you for taking the time to learn this important information. And Linda, just best of luck for you.
Yeah. Thanks. Thank you, Linda. And Linda, if you want to stay on for a bit, we don't just hang on just a moment, and I'll take care of it. Thanks, everyone, and hope to see you again, either in person or online. Bye-bye. All right. Okay, there we go. All right, it is just us now. All right, nicely done. Wow.
Yes.
Thank you so much.
Yes.
I have to say, awful as the pandemic was, and it was awful, the use of Zoom, which it brought us because we didn't know how to do this before, has been very beneficial to the library, and I hope to you, Linda. I mean, just this ability to communicate so easily.
I know,
it's
it's
something
amazing.
out of science fiction.
I know, it is pretty amazing. I know. I'm actually thinking about, so one of the organizations that I have been referred to is Rotary International. Like they, I was talking to someone here about that. They had gotten a grant from them, and I'm like, okay. So I mean, I've done lots of talks to the Rotary clubs around there, and I'm going to explore that option. So,
Good.
yeah.
And
So
maybe
I-
start with one of the Rotaries here too in Maine. I
Yeah.
don't know.
Yeah, I've got a
that's
couple of contacts, so I'm going to be sending, we have to tone up our executive summary, but then I'm going to be sending it out to them and seeing, it would be neat. Wouldn't it be so cool if there could be a partnership between the island and here
Yeah.
to get this funded? And we're talking about, like, we're talking about building a whole maternity unit. And if we had, if we had like $300,000, which that's it, like we could build it for that, which is nothing, as far as US standards go for building a
Oh my
whole health
goodness.
center. Yeah. But that would be all we would need. So yeah, well, I'm not giving up on it. So
Don't give up.
yeah.
Don't give up. You're inspiring. So do not give up. And yeah, I think you should like contact Rotaries, and if there's a Rotary in Malawi, then there
There
should
is.
be one.
There
They-
is. So I found out you have to partner. There has to be a partnership. I
Yeah.
found out. So
Yeah.
that would be cool.
That
So,
will.
yeah. Thank you so much.
Thank you.
Thank
And I
you.
just your energy around it, your positivity is just inspiring.
Oh,
So thank
thanks.
you.
It's so awkward to only be seeing yourself when you're talking.
I know.
No,
We
'cause
had it, yeah.
yeah.
So
You know, you
we had,
respond
I
to
think,
all of this.
six people on that were, so that's half the people, and I like to put in a couple more for couples. So I think we have probably had about maybe 8 or 9 people in addition to us.
Oh, okay.
So I think
Right,
that's
great.
great, and we'll get the word out. And please feel free, Linda, also I'll send you the link, but feel free to spread this video everywhere, because I really
Okay.
think it's really important. So thank you.
Great. Thank you so much.
Yeah.
Thank
Have a
you.
great rest of your day. And hey, the power didn't go out.
I
So-
know. I know. I was so nervous about that.
It's all
So
right.
just okay.
Okay.
All right. All right.
Thank you.
Bye
Thank you
now.
both. All right.
Okay.
Bye-bye.